So we're going to be talking about the evaluation and differential diagnosis piece of vestibular dysfunctions. So as we've talked about already, there are peripheral vestibular dysfunctions. So we're thinking that that's going to be in the vestibular nerve, so the cranial nerve. It could be in the semicircular canals. It could be in the otoliths, in the labyrinth, anything. We're thinking more it's the actual inner ear structure when we think about peripheral vestibular dysfunction. Central is going to be past the cranial nerve. So we're going to be thinking more that it's going to be in the vestibular nuclei, could be in the cerebellum, could be in the cortex, but that's where more of our central dysfunction is going to come from. All right, so when we talk about the peripheral vestibular system, we have a couple different types that we are going to kind of categorize them in. So the first one would be mechanical disorder, which would be our BPPV. So we've been spending our last few days on lab going over the BPPV, so we're not going to be spending any more time on that today, but just note that that is considered a peripheral vestibular system dysfunction. Okay, the next one would be a unilateral vestibular hypofunction. Examples of this could be a neuritis, and we're going to go into these examples in a little bit more detail, but a neuritis, it could be labyrinthitis, acoustic neuroma, perilymphatic fistula would all be examples of a unilateral hypofunction. So only one side is impacted and causing issues with the vestibular system. You could also have a bilateral vestibular hypofunction. Usually the only way that's going to occur is going to be due to ototoxicity. So if you remember, we talked about taking certain antibiotics such as agenomycin. Those are ototoxic, meaning that they'll kill the hair cells. And once hair cells are gone, you can't grow new ones, okay? But sometimes people can have an idiopathic reason for their bilateral vestibular hypofunction. There's also Meniere's disease, which is kind of its own category, but they're going to have repetitive bouts of vestibular symptoms and events throughout their life. And then you'd also have migraines. You can have vestibular migraines. So let's talk about the history taking. How does that look? A little different depending on the type of diagnosis that you are dealing with or dysfunction. So all this stays the same. We still want to think about knowing what the primary symptoms are. We want to think about knowing what the secondary symptoms are, provoking positions, symptom onset, latency, duration, and our oculomotor exam. All right, so for unilateral hypofunction, there can be an acute phase and there can be a chronic phase. And we're going to break them up because remember when we talked about like red flags versus yellow flags, as far as with the oculomotor, there are some things that you're going to see in the acute phase of a vestibular hypofunction that will kind of mimic what a central dysfunction might look like. But once again, if it's going to be a peripheral issue, then we're looking at either the semicircular canals, inflammation of the nerve, tumors, things like that. What ends up happening is there's a weakness on one side compared to the other. Okay, so for whatever reason, something's going on in one of the inner ear structures that is causing a hypofunction or a weakness on that side. Acute phase usually lasts about 1 to 2 weeks after the initial symptoms come on. So what are we going to see in this acute phase? Their primary symptoms are they're gonna have vertigo or dizziness and nausea. So it's going to come on really suddenly and it's going to come on hard and fast. Very different than the BPPV where it's only going to last for a few seconds. This is going to last a lot longer than that. Okay. Secondary symptoms though may still include imbalance, difficulty walking, fullness in the forehead, falling, things like that. Movement to the head is going to provoke them. Okay. It's a unilateral hypofunction. It's an acute stage, which means any kind of movement. So if you're moving any of the circular semicircular canals that are involved, you're going to provoke the symptoms. So the symptom onset is going to be sudden. Frequency is going to be episodic. So if they move their head, we're going to go ahead and have symptoms. But the difference between that and the BPPV is that it's going to be minutes to hours. Okay. And it could be multiple different motions that are setting them off versus like every time I roll to the left or things like that. So in the acute phase, almost everything's going to start bothering them initially. Okay. But when we look at the oculomotor exam, their smooth pursuit's going to be normal. Okay. So we're not seeing a central sign. Saccade should be normal as well. It's not a central in nature. VOR cancellation would also be normal. But the spontaneous nystagmus, we're going to see that. Okay. But you should be able to suppress it by fixation. If you cannot, it should be in the same direction no matter which way you go. Okay. So if you look to left, right, up or down or whatever, the nystagmus is always going to beat to the excitatory side. So it should always beat towards that excitatory ear. Okay. And it's going to increase when you look towards the lesion. So when you're looking at the nystagmus is going to get worse when they actually look towards the side of the lesion. But if it's left beating, it's going to stay left beating. If it's right beating, it's going to stay right beating. Okay. The cover uncover in the acute phases may also be abnormal for the first 1 to 2 weeks. So you may see a skew deviation occur when you do that test in the first couple weeks. VOR is going to be abnormal. The thing that's going to help us determine whether it's central versus peripheral, on top of looking at the smooth pursuit and the saccades, is going to be the head impulse or the head thrust test. Okay. It will be abnormal with head movement in the direction of the lesion. So if we turn the head to the left and the left side is impacted, we're going to see that catch-up saccade to the right. So we'll have a positive head thrust or head impulse test with an acute hypofunction. DVA is going to be abnormal. When we go into the Dix Hallpike, it is going to be negative, or this is when you might see that non-fatigable horizontal nystagmus. Okay, so in that really acute phase, you could see that, but it's horizontal. It's not going to be upbeating or downbeating, which would give you that cue that that's not really an anterior posterior canal issue if we see that type of nystagmus when we drop them back in the Dix Hallpike. So our key indicator that's going to help guide as far as an oculomotor test is going to be that head thrust or head impulse test. Okay, there's another one out there called head shaking. It's not used quite as much, but that is another test you can use to assess for peripheral dysfunctions. Calorics, we don't do those ourselves. So if you remember the saying, cows, you shoot the water in the ear. Cold opposite, warm goes the same. So what they do is they do the calorics when they're at the ENTs, and they'll do readings. But if there's more than a 25% weakness from one ear to the other, that would be considered a hypofunction. So they do see the ENT and you get the report back, it'll tell you what percent hypofunction they have or deficit weakness they have on one side. So that's a key indicator that they're having a unilateral hypofunction as well. VOR and DVA, they're just very general. They're not specific. So while we could look at them, they're probably going to have deficits. It's not going to really tell us if it's peripheral or central in nature. So how is chronic different than from acute? So chronic is going to occur in the later phases. So this could be weeks to months down the line. They still may be having a chronic vestibular hypofunction because maybe they had that acute phase, never had therapy, just never really had it treated. It didn't compensate correctly. And so they're still having issues. But now, instead of complaining about the vertigo and the nausea like they did when it first happened, they're going to be talking more about feeling off balance. Okay, so their primary symptom description is going to change. They're still going to have issues such as difficulties walking in busy environments. They may feel fullness in their forehead, swimmy headed. Typically, it's going to get worse as the day goes on, and they may complain about falling, especially when they're doing head turns or turning activities. Provoking activities, not necessarily movement related. Usually it's going to be more that they complain about they have difficulties in an open and busy environment, riding in a car, or turning activities, or dark environments. So symptom onset, sudden initially, but it happened several days or weeks ago. They're having symptoms daily, gets worse as the day goes on. And initially the symptoms were minutes to hours. Now it just tends to increase with activity as the day goes on. So they won't give you quite like it lasts for this long. They'll talk more about it just getting worse as the day goes on. So what would our oculomotor exam look like? So our smooth pursuit is going to be normal. Saccades are going to be normal. VOR cancellation is going to be normal. Once again, there's not a central issue, so those should all be fine. Spontaneous nystagmus now is probably going to change. They're either going to have adapted and gotten used to being able to fixate, and so they can override it now. So you're not going to see the spontaneous nystagmus in room light. However, with somebody who has a chronic deficit, if you actually had the infrared goggles and you were actually able to get rid of the light and do it in the dark, you may actually still see spontaneous nystagmus when they're in the dark. Your cover on cover test at this point is going to be normal. Your VOR still going to be abnormal or mildly impaired. The head thrust, though, is still going to be positive in the direction of the lesion. DVA, once again, could be abnormal or mildly impaired, but you're not going to see anything that Dix Hallpike, so that horizontal nystagmus that you may have seen in the acute phase, you're not going to see in the chronic phase. Okay, so once again, our test to diagnose, it's going to be a huge one for us. It's going to be that head thrust or the head impulse test. So there's several different types of unilateral hypofunction. I have them listed there. We're going to go talk about each one of them here briefly. So it is not really our job to diagnose them per se and say, hey, you have a neuritis, hey, you have a labyrinthitis, da 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 da. Our job is if they come in with us and we're trying to figure out what to do, sometimes it's helpful for us to know who to refer them to. Okay, so when we're thinking about a neuritis or labyrinthitis, a lot of times that's an inflammation. So they might be able to have some type of medication that could help calm that down for them. So that's when we might send them to an ENT or a primary MD to kind of let them know that we think that they might have something like that going on and have them assess further. Okay. But as far as their neuritis goes, they're going to have a gradual onset of vertigo. They're going to have nausea and vomiting over several hours with the symptoms peaking in 24 hours. So it's still going to be somewhat of it's going to come on within a 24-hour period more than likely where it's going to peak and get intense. And then the symptoms will typically last about 3 or 4 days. So they're going to feel pretty rotten for about 3 or 4 days. With a labyrinthitis, they're going to also have a sudden onset of hearing loss. So they're going to have a sudden onset of vertigo, nausea, vomiting, and also hearing loss. So that's going to kind of be a big difference between the neuritis and the labyrinthitis. Symptoms are going to peak within 24 hours and they're going to last 3 to 4 days, kind of like the neuritis. For an acoustic neuroma, gradual unilateral hearing loss, they may have tinnitus with mild disequilibrium. So now we're not looking so much at the vertigo. We're not looking at everything happened suddenly. It's a tumor, and it's a tumor that's growing. Okay. So as it grows, it's going to compress on structures, which is then going to change their symptom intensity. All right. So if the tumor is pressing on the cerebellum or the brainstem, then you may also see abnormalities in smooth pursuit or saccadic eye movements. But notice once again, now it is pushing on a central structure. So it could eventually start to encompass both. Meniere's versus migraines. One, they're not going to follow the normal pattern that you're hearing from everybody else because it's going to kind of like they're going to have a bout, then it's going to go away, then they're going to have a bout, then it's going to go away. So you're not going to hear that with a unilateral hypofunction. It's kind of like one episode happened, it's there, it's gone. Maybe it's not, still not doing well, but you're not going to have that repeated bouts of vertigo like they felt the first time that they had it. Whereas in a migraine and Meniere's, you're going to have that intense feeling of vertigo multiple times versus just once. So anytime they would have the migraine, it could be a vestibular migraine. They're going to have that spontaneous vertigo. They're going to usually have some tinnitus and fluctuating hearing loss, but usually their hearing loss is not going to be permanent and it's not going to be progressive. It may last seconds to days, depending on how long the migraine lasts. Typically, they'll have a history of migraine, and typically they're going to have some type of aura. So they might have issues with light, hearing, things like that, but they're going to usually typically have some type of aura that's going to come with it. With Meniere's, they're also going to have that spontaneous nystagmus. They will have unilateral tinnitus and fluctuant hearing, but it's going to get worse each time that they have their episode of the Meniere's. So they typically eventually will have a permanent progressive hearing loss. So each time they have one, their hearing might get a little bit worse. Okay. Their vertigo is going to be anywhere from 20 minutes to less than 24 hours, and it's episodic, but we're not going to see all the auras and everything else that would come with the migraine. All right. So perilymphatic fistula is the only other one that I'm going to talk about. And typically that patient's going to have a history of head trauma, barotrauma, mastoid or stapes surgery, or vigorous training preceding the onset. So what they're going to feel is episodic vertigo, imbalance, and fluctuating hearing loss. So basically what this is there's a hole in the semicircular canal. So what happens is when you increase your pressure, so let's say you have Valsalva or you're straining, you're doing something, it'll actually push some of the fluid that's in the semicircular canals out of the canal and shoot it through the hole of the semicircular canal or the bony part of the labyrinth. And so when that happens, you're going to see a spontaneous nystagmus occur, or you're going to see a nystagmus occur basically with the episodic vertigo. So it really is only going to come on whenever they're straining or doing something that would push that fluid out of the hole. And that's typically treated with surgery. All right. So we can have unilateral hypofunction. We can also have bilateral hypofunction. So we could just have impairments on both sides. Okay. So that's really when the hair cells and bilateral inner ears have been damaged, but unequally. Okay. In order for them to really complain about symptoms, one side has to be more damaged than the other. So one would be weaker than the other. If they're both affected equally, they're not going to really have the subjective complaints of imbalance unless they're in the dark or it's really dim because they can't use it. So if they're in a situation where they can't use their vision and they can't use the somatosensory, and their vestibular system is weak, then they're going to have issues there with falling or imbalance. Okay. But they won't have that traditional, like during the day type sensations that we're going to talk about. So their primary symptoms are going to be more dizziness, imbalance versus vertigo. Symptoms are usually going to be gradual because the hair cells are going to die over time. If you're using like an antibiotic or whatever that's attacking the hair cells, it's going to be a gradual onset as those hair cells die. We're going to see a greater weakness. Okay. But the frequency, it's going to be constant. The symptoms are really always going to kind of be there because that imbalance or that weakness is always there. So they may last hours to days when they talk about their symptoms. So their oculomotor exam, smooth pursuit, saccades, VOR cancellation, all those things are going to be normal. They're not going to have any problems with the Dix-Hallpike. Things that might be abnormal when we're doing their eval, we could see some abnormal VOR and DVA, but we're also definitely going to see a positive head thrust or head impulse test, and it's going to be positive bilaterally. So no matter which way you turn their head, we're going to see a bilateral um, head thrust. Okay, so how does central vestibular dysfunction or hypofunction different from the other ones? All right, remember when we think about central, we're thinking about there's damage to the vestibular structures higher than cranial nerve 8. So it could be the vestibular nuclei, the cerebellum, the cerebral cortex, etc. Most of the time, we're going to be thinking out this may be due to a concussion, CVA, head injury, MS, other diagnoses similar to that. So what are their symptoms going to be like? They're going to probably complain more about dizziness and imbalance as well versus the vertigo. Depending on what's causing it, it could be gradual or it could be sudden. If it's a patient with a stroke, they might have a sudden onset of vertigo. So that can be a little deceiving sometimes when we say gradual, but if it's something more from MS or other things, it might be more of a gradual onset. Frequency, a lot of times is constant, and so it could last hours to days. So in their oculomotor exam, this is where if it's central, we'll probably see abnormalities in smooth pursuit eye movements. We're going to see abnormalities potentially in their saccades. We may see abnormalities in spontaneous nystagmus, and so there may be spontaneous nystagmus present, or we may also see direction changing nystagmus, gaze invoked nystagmus. If it's purely downbeating and just stays downbeating, not suppressed by fixation, it doesn't fatigue, those are all going to be indicators that we need to think that it's more probably a central issue, but we're going to cluster that with our smooth pursuit saccades and some of our other oculomotor exam tests, okay? VR cancellation as well is probably going to be abnormal, all right? Cover uncover may be abnormal, and VOR may also be abnormal. So this is a little chart that you guys can utilize that I put in here, which is a great way to kind of look at when you're doing your differential diagnosis to help kind of break down like what are the key indicators that might guide me towards one diagnosis towards another. So you can see under onset, frequency, duration, I have some that are highlighted in green. So the big ones that are kind of different would be that unilateral vestibular dysfunction acute and BPPV because they're kind of sudden and they're episodic, but their times of how long their things are going to last are going to be very different. Remember, BPPV is going to just be seconds to minutes and it's going to be done. Whereas in that acute stage, their symptoms are going to last more minutes to hours. Okay. But the differentiator is going to be our Dix-Hallpike versus our head impulse test. Okay. And figuring out which one is positive will guide us as to which way they're going. Okay. From a central, we know that nystagmus is going to be very different looking if they have spontaneous nystagmus. Okay. And then they're going to be having issues with saccades, smooth pursuit, VOR cancellation. Okay. So if you like to see things in a chart and kind of like as you're listening to things, want to be like, oh, check, 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 these are all kind of fit in this box. That might help guide you when you're trying to use your differential diagnosis reasoning as you're trying to clinically reason through what type of dysfunction you think your patient has. And that is all I have for you on this presentation.